Welcome to vpod.ai and welcome back for another deep dive. Today's deep dive is brought to you by Stonefly. They're your trusted solution provider and advisor in, well, pretty much everything data related. Enterprise storage, backup disaster recovery, hyper-converged clusters for VMware, Hyper-V, Proxmox, AI servers, ASA 365, that's a turnkey security appliance, and public and private cloud solutions too. Definitely check them out at stonefly.com for more info. Right. So our mission today is to really cut through the complexity surrounding ovarian cancer. We want to unpack the latest advancements, the critical insights, basically give you the important nuggets from a whole lot of material. It's a shortcut to getting properly informed. Because look, it's a huge health challenge, no doubt, but there's also something of a quiet revolution happening in how we understand it, how we fight it. So let's unpack this. I mean, I've read that ovarian cancer has been notoriously hard to catch early for years. Why is that? What do the stats actually tell us?
Yeah, that's really the core of the challenge, isn't it? The major unmet need is still that most patients aren't cured. The numbers are, well, they're pretty stark. You're looking at around 70 to 75% of patients presenting in stage 3 or 4, that's advanced. And of those patients, another 70 to 75% sadly won't be cured. When you compare that to success rates in, say, some other cancers, those numbers are frankly pretty bad. It really underscores why the research and the new treatments we're going to talk about are so vital.
75% diagnosed late, and then 75% of those not cured.
Wow.
Exactly. And a big part of that late diagnosis comes down to screening, or rather the lack of it. Unlike breast cancer, for instance, where mammograms make a huge difference in early detection, we just don't have an effective, widely used screening test for ovarian cancer yet. That's the key reason so many women present at these advanced stages. Current guidelines might involve ultrasounds, but honestly, they're not great at picking up stage 1, stage 2, or, crucially, precancerous changes.
So no equivalent of a pap smear yet, basically. Not yet, but that's where the hope lies. There's some really exciting research happening looking at blood tests. They're investigating different markers, things like circulating tumor DNA, even free cancer cells floating in the blood. The hope is, yeah, to develop something much better for catching precancers, maybe something like a pap smear for cervical cancer. That would be a total game changer for early detection.
Okay, that potential for earlier detection sounds incredible. But before we dive deeper into treatments, maybe we should quickly cover the basics, like what is ovarian cancer? Is it just one thing?
Good point. No, it's definitely not just one thing. Understanding the types is really fundamental because they behave very differently, and that affects treatment. Broadly, there are 3 main types. The most common, by far about 85% of cases, and sadly around 95% of deaths, are the epithelial ovarian cancers. These usually start in the cells lining the fallopian tubes or the ovaries themselves, or sometimes the peritoneum, which is the lining of the abdomen. And yeah, these are the ones that typically show up late.
Okay, 85% epithelial. What are the others?
Then you have germ cell tumors. These start in the egg-producing cells. They tend to affect children and younger women more often. The good news there is that they generally have a much better prognosis, often quite curable with surgery and chemo. And the third type is stromal cell tumors. These are pretty uncommon, less than 5% of cases. They start in the supportive connective tissues of the ovary and are usually slow-growing. So you see, same organ, but very different diseases, really.
That distinction is clear. And you mentioned epithelial cancers are the most common and often present late. Is there a genetic component we should know about there?
Yes, absolutely. Especially with the high-grade serous type, which is the most common subtype of epithelial cancer. We know that somewhere between 15 and 20% of these cases are directly linked to inherited mutations, specifically in the BRCA1 and BRCA2 genes. You've probably heard of those.
BRCA, yeah. Linked to breast cancer risk too, right?
Exactly. And the risk increase for ovarian cancer is significant. With a BRCA1 mutation, the lifetime risk jumps to somewhere between 35 and 70%. For BRCA2, it's about 10 to 30%. Compare that to the general population risk, which is less than 2%. It's a massive difference.
That's good, Chetler.
And it's not just BRCA1 and 2 anymore. Genetic testing panels now often check for mutations in maybe 19 or so different genes that can increase risk. We also look for things like Lynch syndrome, which is another inherited condition that raises the risk not just for ovarian, but also colon and uterine cancers.
So this genetic testing, it sounds like it's becoming really central. Who should get tested?
That's a key point. The current recommendation is that everyone diagnosed with ovarian cancer should have genetic testing. Everyone. And there are 2 types of testing to understand. There's testing for those inherited germline mutations we just talked about. That's usually done via blood, saliva, or a cheek swab. That tells you about lifetime risk and has implications for family members too. Then there's testing the tumor itself for somatic mutations, changes that are only in the cancer cells, not inherited.
And why test the tumor specifically?
Because those tumor-specific mutations can guide treatment choices, especially now with targeted therapies like PRP inhibitors. Knowing the tumor's genetic makeup, like its BRCA status or something called HRD status, is critical for deciding on the best treatment path, particularly for maintenance therapy after chemo.
Right, got it. Okay, so moving from the genetics to actually finding the cancer, you said symptoms are often subtle early on. What should people be aware of?
Yeah, the vagueness is a real problem. We're talking about things that are pretty common, unfortunately. Persistent bloating that doesn't go away, heartburn, pelvic or abdominal pain, feeling full really quickly when eating, needing to urinate more often or regently, maybe pain during sex. The key flags, the things that should make you think, okay, I need to get this checked, are if these symptoms are relatively new, like started less than a year ago, if they're happening frequently, say more than 12 days a month, and if they seem to be getting worse.
And if someone presents with those persistent symptoms, what's the initial workup like?
Well, the doctor will do a thorough history, of course, an abdominal exam, and a pelvic exam. It's important to remember, though, that a pap test, while crucial for cervical cancer, doesn't screen for ovarian cancer. Sometimes they might do a rectovaginal exam or maybe an endometrial biopsy to rule out issues with the uterus lining, but the focus is figuring out what's causing those pelvic symptoms.
Okay, and if those initial exams raise concerns, what's next? Imaging.
Exactly. Imaging is key. Often, the first step is an ultrasound. It uses sound waves, can be done over the abdomen or transvaginally, and it's good for looking at the size and shape of the ovaries and uterus and seeing if a mass is solid or filled with fluid. Then, CT scans are really useful. They use X-rays and a contrast dye to get detailed pictures, particularly good for seeing if cancer has spread outside the ovaries, like to lymph nodes or other abdominal organs.
What about MRI or PT scans?
Yeah, an MRI might be used if the ultrasound results aren't quite clear. It uses magnets and radio waves, no radiation, gives very detailed images, but it takes longer. PT scans are different. They look at metabolic activity. Cancer cells often use more sugar, so a PET scan can sometimes spot smaller groups of cancer cells or check for spread, often combined with a CT scan called a PET-CT. And sometimes a simple chest X-ray is done just to check if there's any spread to the lungs. For advanced cancer, sometimes a surgeon might do a diagnostic laparoscopy first, that's keyhole surgery, just to get a direct look inside the abdomen and see the extent of the spread before planning a bigger operation or starting chemo.
So lots of different ways to get a picture. But the definite answer, the actual diagnosis, that has to come from looking at the cells, right? A biopsy.
Precisely. A biopsy is essential. Usually, tissue is obtained during the initial surgery to remove the tumor. But if the plan is to give chemotherapy before surgery, maybe to shrink large tumors, then a biopsy is done beforehand to confirm the diagnosis. This could be a fine needle aspiration, FNA, a core biopsy using a larger needle, or if there's fluid buildup in the abdomen called ascites, they might do a paracentesis to draw off some fluid and test it for cancer cells. Pathologists then examine that tissue or fluid under a microscope. They determine the type of ovarian cancer, as we discussed, and also the grade.
Okay, grade versus stage, what's
Sure.
the difference there?
Good question. They're easy to mix up. Stage tells you how far the cancer has spread physically in the body. Grade, on the other hand, describes how abnormal the cancer cells look compared to normal cells. A higher grade generally means the cells look more abnormal, and the cancer might grow or spread more quickly. Both stage and grade are really important for planning treatment and predicting prognosis.
Got it. And are there blood tests involved in diagnosis too? You mentioned CA-125 earlier.
Yes, blood tumor markers play a role. CA-125 is the most well-known. It's often elevated in ovarian cancer, but importantly, it can also be raised by benign conditions like endometriosis or fibroids. So it's not used alone for diagnosis. It's actually more useful for monitoring how well treatment is working or checking for recurrence after treatment. There are other markers too, like HE4, inhibin, AFP, depending on the suspected type of ovarian cancer. But the really exciting area now is biomarker testing on the tumor tissue itself. This is also called molecular testing or genomic profiling.
That sounds like what you mentioned before, testing the tumor's genes.
Exactly. It looks for specific DNA changes or protein levels in the cancer cells. This is critical for guiding treatment, especially targeted therapies and immunotherapies. Key things we look for are those BRCA mutations again, but this time in the tumor, and also homologous recombination deficiency, or HRD status. Knowing if a tumor is HRD positive or negative directly impacts whether PRP inhibitors are likely to work. Other markers might include MSI, MMR, HER2 status, tumor mutational burden, TMB, BRAF mutations, FR alpha levels, RET, NTRK fusions. It's getting incredibly personalized.
Wow, okay. So once all that information is gathered, the type, grade, biomarkers, then comes staging, determining how far it's spread.
Correct. Staging is crucial for treatment planning. We usually use the Fagot staging system. It goes from stage 1 to stage 4, with substages A, B, C within those. Stage I basically means the cancer is confined to one or both ovaries or fallopian tubes. Stage 2 means it's spread to other pelvic organs like the uterus, bladder, or rectum. Stage 3 is where it's spread beyond the pelvis into the abdominal cavity lining or to nearby lymph nodes behind the peritoneum. This is, unfortunately, where many patients are diagnosed. And stage 4 means it's spread to distant sites, fluid around the lungs, inside the liver or spleen, or to distant lymph nodes or other organs.
Understanding that stage seems absolutely critical for deciding on the treatment approach. Which brings us to the treatments themselves. It sounds like it takes a village, a whole team.
It really does. Optimal care involves a collaborative care team. Ideally, the initial surgery is done by a gynecologic oncologist, a surgeon specializing in female reproductive cancers. They really have the expertise needed for the complex surgery often required, but they work alongside medical oncologists who manage chemo and targeted therapies, radiation oncologists if needed, specialized nurses, social workers, genetic counselors, nutritionists. It's a multidisciplinary effort focused on the whole patient.
And surgery is usually the first step, right? You mentioned debulking.
Yes, for most patients, surgery is the cornerstone, often the first treatment. The main goal is cytoreductive surgery, or debulking. That means removing as much visible cancer as possible. Ideally, the surgeon aims for optimal debulking, meaning no visible tumor larger than 1 centimeter is left behind, or even better, no visible disease at all. The standard surgery is usually a total hysterectomy, removing the uterus, and a bilateral salpingo-oophorectomy, or BSO, removing both ovaries and fallopian tubes. They'll also typically take lymph node samples and biopsies from the abdominal lining. In very specific cases, usually very early stage, low-grade cancers in younger women who want to preserve fertility, a fertility-sparing surgery might be possible. This might involve removing only the affected ovary and fallopian tube, a USO, and leaving the uterus and other ovary.
That's a huge consideration for younger patients. How is the surgery usually done? Big incision.
For comprehensive staging and debulking, the most common approach is still a laparotomy, which involves a larger vertical incision in the abdomen. This gives the surgeon the best access to remove all the disease. Laparoscopy or keyhole surgery might be used for staging in seemingly early cases or for certain procedures, but it's less common for the main debulking surgery for advanced disease. Recovery involves a hospital stay, usually several days, maybe longer depending on the extent of the surgery, followed by several weeks of recovery at home.
On removing both ovaries. That triggers menopause instantly, right?
Yes, that's a significant consequence, surgical menopause. Because the ovaries are the main source of estrogen, removing them causes an abrupt drop in hormone levels. This can lead to quite sudden and often severe menopause symptoms. Intense hot flashes, night sweats, sleep problems, mood changes, vaginal dryness, and atrophy. And there are long-term health considerations, too, like increased risks for heart disease and osteoporosis. Managing these effects is really important, and there are options, both non-hormonal treatments and, in some cases, hormone replacement therapy, HRT, that need to be discussed carefully with the care team.
Okay, so surgery tackles the visible disease. Then comes chemotherapy, usually, to clean up anything left behind.
Exactly. Chemotherapy is a systemic treatment, meaning it travels through the bloodstream to kill cancer cells anywhere in the body. It's used either after surgery, adjuvant chemo, to target any microscopic cells left behind, or sometimes before surgery, neoadjuvant chemo, to shrink tumors and make them easier to remove. The standard backbone is usually a platinum-based drug, like carboplatin or cisplatin, often combined with a taxane like paclitaxel.
How is it given? Pills?
Usually intravenously, meaning dripped into a vein. It's typically given in cycles like 1 treatment every 3 weeks for about 6 cycles. Many women have a portacath, or port, placed under the skin to make 4V access easier and more comfortable over the months of treatment. Sometimes chemo can be given intraperitoneally, IP, directly into the abdominal cavity through a special port. This delivers a higher concentration of chemo right where the cancer spread is often worst. It can be effective, but it also tends to cause more intense side effects. There's also something called HIPEC, hyperthermic intraperitoneal chemotherapy. That's heated chemo washed through the abdomen during surgery, usually interval debulking surgery after neoadjuvant chemo for some stage 3 patients.
Chemo side effects are often what people worry most about. What are the common ones?
Yeah, they can be tough, though management has improved a lot. Common ones include nausea and vomiting, though anti-sickness meds are much better now, loss of appetite, mouth sores, fatigue, and, yes, hair loss with many regimens. Because chemo affects fast-growing cells, it can also lower blood counts, leading to increased risk of infection, low white cells, bruising or bleeding, low platelets, and anemia, low red cells. Nerve damage, called peripheral neuropathy tingling or numbness in hands and feet, can also happen, especially with taxanes. While rare, there are potential serious long-term risks like developing myelodysplastic syndrome, MDS, or acute myeloid leukemia, AML, years later, but that's uncommon.
Okay, beyond chemo, you mentioned targeted therapies. This feels like where a lot of the newer excitement is.
Absolutely. Targeted therapies are designed to attack specific vulnerabilities in cancer cells, often based on those biomarker tests we talked about. They tend to be more precise and sometimes have different side effect profiles than traditional chemo. The biggest players right now are the PRP inhibitors, drugs like olaparib, niraparib, and rucaparib. They essentially block a DNA repair pathway. Cancer cells with BRCA mutations or that are HRD positive are already bad at repairing DNA, so blocking another pathway with a PRP inhibitor is often lethal to them.
So they exploit a weakness the cancer cell already has.
Exactly. They're most effective in those specific groups and are often used as maintenance therapy after the initial chemo has worked. The idea is to keep the cancer in remission for longer. Patients might stay on them for 2 or 3 years. Side effects can include fatigue, nausea, and effects on blood counts, similar to chemo in some ways. And, like chemo, there's that very small risk of MDS-ML long-term.
Are there other major targeted drugs?
Yes. Another important one is bevacizumab, brand name Avastin. This is different. It's an anti-angiogenesis inhibitor. It stops tumors from growing new blood vessels, effectively starving them. It's often given with chemotherapy and can also be continued afterwards as maintenance therapy. Then there's a newer antibody drug conjugate called mirvetuximab soravtansine, Elahere. This is specifically for platinum-resistant ovarian cancer that has high levels of a protein called folate receptor alpha, FRAIR. It delivers chemo directly to those cells. And for a rarer type, recurrent low-grade serous ovarian cancer, a drug called trametinib, which targets a pathway called MEK, can be an option.
So lots of options targeting specific features. What about harnessing the immune system, immunotherapy?
Yes, immunotherapy is another rapidly evolving area. The goal here is to help the patient's own immune system recognize and attack the cancer cells. Drugs called checkpoint inhibitors, like dostarlimab, Jexley, or pembrolizumab, have shown promise, but mainly in a subset of ovarian cancers that have specific biomarkers, like being DMMR, mismatch repair deficient, or MSIH, microsatellite instability high, or having a high tumor mutational burden, TMB. It's not yet a standard approach for everyone, but it's a key area of research. And briefly, hormone therapy using drugs to block estrogen can sometimes be used, usually for less common, low-grade stromal tumors, or sometimes low-grade serious cancers that are hormone receptor positive. It aims to slow their growth.
And radiation, you mentioned it's limited.
Yeah, radiation therapy isn't a mainstay for ovarian cancer treatment like it is for some other cancers. Its role is generally palliative, meaning aimed at relieving symptoms. For example, it might be used to control bleeding from a tumor in the pelvis or to treat painful bone metastases if the cancer has spread there. A potential side effect if the pelvis is treated is vaginal stenosis, a narrowing or scarring of the vagina.
Okay, that covers the main treatment modalities. What about after treatment? Living with ovarian cancer often involves dealing with the possibility of recurrence, right?
Unfortunately, yes. Especially for those diagnosed at later stages, recurrence is a significant concern. That's why regular follow-up is so important. This usually involves regular checkups with physical and pelvic exams and monitoring that CA-125 blood marker. Imaging might be done if symptoms arise or CA-125 starts to rise consistently. Symptoms of recurrence can be similar to the initial symptoms, returning pain or bloating, unexplained weight loss, stomach issues, fatigue, urinary changes. It's crucial for patients to report any new or persistent symptoms.
And if cancer does come back, what happens then? Is biomarker testing important again?
Absolutely. If recurrence happens, reevaluating the cancer's biomarkers is often recommended as the cancer might have evolved. Treatment depends heavily on when the recurrence happens relative to the last platinum-based chemotherapy. If it recurs within 6 months, called platinum-resistant recurrence, the cancer is less likely to respond to platinum drugs again. Treatment usually involves different non-platinum chemo agents, like weekly paclitaxel or liposomal doxorubicin, often given with bevacizumab. And for FR-alpha positive tumors, mirvetuximab soravtansine is an option here. If it recurs more than 6 months after finishing platinum chemo, called platinum-sensitive recurrence, then retreating with a platinum-based combination is often effective. In some select cases of platinum-sensitive recurrence, secondary debulking surgery might be considered if it looks like all visible disease can be removed again.
And PRP inhibitors can come back into play here too.
Yes, for patients with platinum-sensitive recurrence, particularly those with a BRCA mutation, using a PRP inhibitor as maintenance therapy after the second round of chemo response is a key strategy to prolong that remission.
It really highlights how dynamic treatment has become, which leads to clinical trials. How important are they?
Hugely important. Clinical trials are how we make progress, how we find better treatments. They test new drugs, new combinations, new surgical techniques. They're structured in phases. Phase 1 focusing on safety and dosage. Phase 2 on preliminary effectiveness. Phase 3 comparing the new approach to the current standard of care. And Phase 4 looking at long-term effects after approval. Participating in a trial can give patients access to potentially cutting-edge therapies, often years before they become widely available. It's especially important to consider for recurrent or platinum-resistant disease where standard options might be limited.
Are people just given sugar pills in trials?
That's a common misconception. In cancer trials, placebos are very rarely used alone. If a placebo is used, it's almost always in addition to the standard of care treatment, or the trial compares the new drug directly against the current best standard treatment. Patients are always fully informed about the trial design, potential risks, and potential benefits, and they can withdraw at any time. Encouraging participation, discussing options with the care team that shared decision-making is vital.
And beyond the medical treatment, what about support?
Crucial. Getting a second opinion, connecting with support groups, reaching out to patient advocacy organizations like the National Ovarian Cancer Coalition, NOCC, or the Ovarian Cancer Research Alliance, OCRA, can make a huge difference. They offer resources, information, and connection with others going through similar experiences. We also need to focus on holistic survivorship care, managing long-term side effects, collaborating with primary care doctors, addressing the financial impact of treatment, promoting healthy lifestyle habits, and sometimes integrating complementary therapies alongside conventional medical care.
It's a complex journey, but it sounds like there's more reason for hope and more personalized options than ever before.
Definitely. The progress, particularly in understanding the genetics and tailoring treatments like PRP inhibitors, has been remarkable in the last decade. There's still a long way to go, especially in early detection, but the momentum is strong.
As we wrap up this deep dive, it really is incredible to think about how peering into the unique genetic code of these cancers is changing everything, not just treatment, but potentially prevention too. It makes you wonder, doesn't it? If we can pinpoint this battle at such a microscopic level, based on our own DNA, what other complex diseases might we be able to tackle with similar deep diving insights in the future? It's a fascinating thought. We do want to thank Stonefly again for sponsoring today's deep dive. And just a reminder, Stonefly offers powerful data solutions, including their 100 TB immutable and air-gapped SSO NAS, available right now for $8,995. That's SSO single sign-on NAS. You can find out more about that offer and all their enterprise storage, backup, hyper-converged, and cloud solutions over at stonefly.com. We hope this has been valuable for you. We encourage you to keep doing your own deep dives into the topics that matter. Thanks for joining us, and until next time, keep learning.